I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. And I'm excited today to have Preston Alexander as our guest. I think we've got a really exciting topic coming up. Preston, thank you for joining us.
Thanks so much for having me. It's great to be here, great to be back, and look forward to speaking with you and hopefully answering some of those questions that people don't think they're allowed to ask.
Awesome. So tell us a little bit about yourself, Preston.
Sure. So I got my start in healthcare. I like to go all the way back to the beginning. A little over 10 years ago in medical device. So I went to grad school and then found myself at a product management job at a global med device company. And while I was there, it was really interesting, fine time. We made some really cool devices and just had this sort of suspicion that there was so much more to healthcare than what I was seeing and what I was exposed to. So over the next several years, I decided to really take to the internet and take to LinkedIn, and you may have seen me there here from time to time, to write about healthcare. And I did that really as a means to learn more and understand and connect with folks, and was fortunate enough to connect with a lot of physicians and healthcare leaders and learn really the ins and outs and depth of healthcare in a much different way than just selling, disposable surgical devices into a hospital. Important work for sure, but again, trying to understand the complexities and general overview. And along the way, I came up with just the thought that, through the complexity of healthcare, there has to be a simpler solution. And one of the simplest things that you see in healthcare is a physician's and a clinician's relationship with the patient. So deciding that was the focus that I wanted to undertake and the mantle that I wanted to take up is how do we make healthcare better for both sides of that equation? And I do so from a business seat and looking at the business side of healthcare and helping clinicians, physicians take back the business of healthcare from this very complex, hydra that we now have. And I do that in two ways. I have help with a couple companies, /Health, and we are a financial management company for private practices. We have a cool SaaS platform that helps you see profitability like you've never seen before in the practice. We also do revenue cycle management. And then I also help manage and run a law firm. And most of our clients are, or many of our clients are private practice physicians. So we also work with digital health tech startups. And again, the goal of all of this is to create better solutions in healthcare. And it's been a real privilege to be able to support so many physicians and other clinicians to make their dreams kind of come true in starting businesses and running them, but also to see a more holistic equation come together where patients are also getting better access to care, more affordable care, higher quality care, in a otherwise troubling healthcare system in the U.S.
Awesome. Now, you mentioned the hydra. For those that may not be familiar, the hydra is a mythical creature from, I believe, Greek mythology. You cut off one head and then you have multiple that grow back. It's actually based on a microscopic organism, a parasite that we sometimes study in biology classes. But how did we end up with this hydra?
That's a great question. I don't know. The total history of it is probably beyond my pay grade, but I think back a lot to, and I think why I call it a hydra, because a lot of where we are today came from well-intentioned individuals, and it just led to some unintended consequences. I think one of the most salient examples and great examples that we're still living with today is the ACA. So as part of the Affordable Care Act, there was a medical loss ratio was introduced, which said that health insurance, large cap had to spend at least 85% of their premium revenue on medical care. And for a smaller insurer is 80%. Well, that creates this, it sounds like the right idea. It sounds like a great kind of move, but then it creates this interesting dynamic and intention because health insurance companies are for-profit entities. And so if you say you can never make more than 15% in profit, gross profit, well, then what lever do they really have? They either need to own more of the profit chain, which means that they vertically integrate. So we see that happening constantly. United Healthcare does it the best. And or we see revenue increase on their side or premium increase on our side. Because if you want to increase profit, gross profit, and you only have so much percentage to work with, the only thing you can do is increase your top line. So that's an example of a hydra. They tried to do something good and say you have to spend most of your money on healthcare delivery, but these other things kind of pop up as a result. So whack-a-mole might be another good, metaphor for it. And then going all the way back in history, to the, I believe was it the 20s or 30s? Baylor, Scott and White, or Baylor at the time, is really where health insurance started, because Baylor was losing money and there weren't enough patients coming in because it was expensive, and healthcare was very different, obviously, in the 20s and 30s. And so they devised the first sort of insurance plan with the teachers in the Dallas area, and they said that for, I forget the exact numbers, but it was like 50 cents a day or something like that, or a week, you basically would get covered to come into the hospital if you needed to. And it would cover up to like $5. I mean, it was some, the numbers are crazy, but it was effectively the first insurance product, and it eventually became Blue Cross, and then Blue Shield came along out in California when loggers were having all these issues and workers didn't want to work anymore because they kept getting injured. And then the employer said, well, we'll pay for your medical care if anything bad happens, and if you come work for us. And then that eventually became Blue Shield. So the origins of health insurance even are noble in ways, right? We wanted folks to have an affordable access, but again, they sort of evolve and transform. And we got to World War II and there were wage freezes. And then, if you can't pay people more, how do you attract top talent? Well, hey, we'll do benefits. We'll pay for your health care. So we saw, insurance, people who were insured, it was something like 15 or 20% of the United States was insured in the early 30s, 40s. And then by the, 60s, 70s, it was 80% of people were insured. So it's just this evolution over time of this really profitable business model. And it sort of is this public good. We need healthcare, but we have these private entities that are profit driven that are supposed to deliver it. And, it just goes a lot of interesting directions.
Let's back up a little bit and let's talk about insurance in general. Not, setting aside the concept of health insurance, because that's, you and I think we can both agree that that's kind of a maybe perversion or distortion is too strong a word, but it's definitely not what insurance. It's evolved into something that's different than what insurance was originally intended, right? So let's talk about insurance in general, setting aside again health insurance. What is insurance? Because I think that's a concept that a lot of people think they understand, but maybe misunderstand.
Yeah, effectively, it's pooling risk so that you can help cover costs, and if they get to a point where you wouldn't otherwise be able to afford it. We have car insurance and we pay our premiums, and if we get in a wreck that totals the car, we're not going to just say, all right, well, I guess that's gone and I owe money for this person and for these medical bills and I got to buy a new car and now I'm out $230,000. You pay $8,000, whatever the deductible is, and then they cover the rest because you've paid into this system and this company, and they're risk pooling from other people and other car owners and things like that, so that if something bad happens, you are quote unquote covered, and they'll pay for an amount by over and above what you would have paid if you didn't have any insurance. And health insurance theoretically should be the same, and the risk pooling in healthcare is even more important, obviously, or else we kind of get into this, what UA Reinhardt called the death spiral is, if you have sicker and sicker people and all the healthy people opt out, then everything just is going to get more and more expensive and out of hand, and no one's going to get paid, and it's going to be, a problem, which it's a problem anyways now, but it's just, let's get a bunch of people together. We'll all pay a little bit. And if one person needs a lot, then there's a pool there and they can avail of those funds to cover the expensive event. I think insurance on its in the simplest form.
Okay. So I've heard it said, and I'd be very interested in hearing whether or not you agree or disagree with this. So I've heard it said that insurance, in its most basic form, is basically a form of legalized gambling. Basically, like, let's say you're the insurer and I'm the insured, right? So I'm going to pick an arbitrary number here, $50 a month, that I am going to have some kind of catastrophic event that's worth $50,000, right? You, as the insurer, are going to bet that hypothetical $50,000 against the $50 that I'm betting, because you know the statistics and it's highly unlikely that you're going to have that catastrophic $50,000 event. And so I'll take your money, $50 a month, because I know the likelihood that I'm going to have to pay out that $50,000 is pretty small. What are your thoughts on that description?
I mean, that's a clever description. I think that there's a lot of merit to that. It made me, for whatever reason, think of when my wife and I bought our first house, we got a home warranty, and we paid however much a year, and and I think we called like one time to some repair guy, and it was like, just in case, we have this warranty, let's use it. And afterwards, and I think he repaired something, but if you look then at how much we paid for the warranty over the course of the years, how much it would have cost if we just called the guy or a person and said, hey, just come over, we need this, and here are the parts, and here is the labor. And if we just paid direct the one time, it wouldn't have cost nearly the amount that we paid for this warranty. So I think there is some merit to saying that it is a gamble, certainly more on our side, or a hedge, perhaps, is another way to think about it, because we're just, I won't use the exact phrase that Chris Rock said, but he has a bit about insurance, and he's like, we should call it in case blank, in case stuff. And then if in case stuff doesn't happen, shouldn't I get my money back? And, because again, you're handing insurance companies this money in case something happens at some point later. Sure. And we rarely question, well, is that advantageous? If I really looked at the numbers, does this make sense for me? And I think that, and in some respects, we still need the people who don't actually use insurance to pay into it, but now you get into some philosophical debate, we'll call it, from a societal perspective, or but in terms of private markets, it really is just a fear hedge, I'd say, more than anything else.
Sure. A form of risk management. Yeah. But, maybe another way to look at it is, every month you're buying this really expensive lottery ticket, and you hope, part of you hopes you win, right? Obviously, nobody wants to have some kind of healthcare disaster, right? But ultimately, that's what you're betting on. You're like, okay, I'm going to roll the dice. I'm going to pay this premium. And, if I win the lottery, then the money that I paid for the premium is worth it, right? And if I don't, then do I get my money back when I buy a lottery ticket?
Yeah.
Of course not.
I think the worst part about it is or one of the poor parts about it, is that you basically are paying a significant amount of money for the right to pay more money for the care.
Right.
So, like, I pay whatever, or somebody pays $400 a month. And then I go to the doctor and they say, great, thank you for I'm glad you've paid $400 a month. Now you owe $2,000 for this whatever visit. Or now you owe us $30 plus we'll bill you for the and you think to yourself, why did I pay the money? The premium is sort of the access, and then the risk pool maybe on the back end, but it's such an opaque mechanism at this point that I have no idea where those premium dollars really go, and how they're being used, and how they come back to me.
Sure. So then, okay, so let's talk about this, the premium dollars and where they go. So when we think about other forms of insurance, like you mentioned car insurance earlier, right? I mean, insurance originally, at its heart, is intended to cover things that meet two criteria, right? They have to be catastrophically expensive and unexpected. I mean, at its heart, that's what insurance is intended to do, right? And that's why, as a general rule, like if you have an indemnity plan for broken bones, you can pay $5 a month and get a $5,000 benefit if you happen to break one of your bones, because it's unexpected and potentially catastrophically expensive, right? So like if a tree crashes on your car, God forbid, right? I mean, that's unexpected. That's catastrophically expensive. Your car insurance is going to cover that. But if it's time for an oil change, I mean, nobody expects their car insurance to cover that because it's not catastrophically expensive and it's not unexpected. How does that differ in our modern health insurance model?
Well, to your point, I mean, it's because we use it for so-called maintenance. I think that we could argue that getting sick is unexpected, but is it catastrophic? If my kid has an ear infection, it's not catastrophic. Although one of my oldest did have her eardrum burst after a quick turnaround on an ear infection, but still, she was okay. We got the antibiotics, like she was fine, not totally catastrophic. But still, yeah, there's some level. The part of another interesting angle of that though too is that the definition of catastrophic would probably need to involve some monetary amount. Otherwise, what's the point of insurance? Because this is a monetary product. So, sure, if God forbid you're in a car accident and you're in the ICU and you're mangled and you need a transplant or this or that, I mean, you think those numbers should actually get high really quickly for good reason. But and even within that, and so much sort of beneath that from an acuity perspective, we don't really say, well, why are these numbers so high in the first place? This was catastrophic from a health medical standpoint, no doubt. But if we couple it to the financial product side, why does it cost $1 million? Why does it cost $3 million? Why did it cost 100? And oh, by the way, a physician only makes, I think it's, what is it, $5,000 something for like a heart transplant if you look at professional fees paid for by CMS. That's preposterous. But we all know that it costs probably $400,000 to get a heart transplant, actually, when you all said and done. And there's a lot that goes into it, no doubt. There's still that flip side of we don't really question it, even at the catastrophic level. So certainly, as you sort of cascade down and say, well, maybe we haven't really quite reached that threshold of catastrophe. And we've started using insurance for all those things. And again, the origin of health insurance we know today started, in Texas. It really was for that routine stuff. Like we wanted more patients in the hospital. Our volumes were down, so we created a product that had people like a subscription service, like a gym membership. Come on in, you're covered based on this model. So that's part of that going all the way back and saying, how did this all evolve? Because it stopped way early on being about catastrophic event or high cost. It almost immediately became about how do we just get more people through the door by creating some sort of insurance or capitated rate almost for those individuals. And so I think that has certainly not helped the ballooning cost of care, because again, I don't think anyone wants to go to the doctor. No offense.
Not taken.
Are lovely people, but like no one really wants to go. So I think that this sort of there's a two sides of the coin, sort of this myth that everybody's gonna just willy-nilly go to the doctor and I love it so much, like MRIs for everybody. No one really wants to do that. So that overutilization, I think it only goes so far. But at the same time, it did create an environment where it made it so that this notion that someone else pays, that we can just go, run the test, give me the antibiotic, let's do the pills, let's go this way, let's do that way. Let me go back. I've had my kids has a fever. Let's go to the doctor. It's been 3.5 hours. And it's like, we can, pause and slow down a little bit. And so, yeah, I think has created some dynamics that have driven utilization a little bit, and certainly, allowed people to feel like they need to use insurance for everything for all of the time. And it's like necessary. But again, it goes to the question, Why does it cost so much? Why are we using this in the first place? Is this product appropriate for going to the doctor? Because if I went and I asked and I said, listen, you're going to bill for what, 99213 on this, 15 minutes? What if I paid you for 20 minutes? What were you going to get paid for the 99213? You know, oh, 80 bucks? Cool. Can I, and you have to bill it, and how long does it take, and who billed it, and whatever. Well, if I give you 50 bucks now, can you hang out with me for 20 minutes and we can talk about my health problems? And like, maybe, sure. We don't take all the junk out of the middle and say, like, if we just transacted this normally, paid someone for their value, their time, what does that look like?
Right. Right. And I'm glad you brought up that question. You know, why does X cost $1 million? Why does Q cost $3 million? So why does it cost so much money?
I mean, great question.
I mean, obviously that's a complicated answer, right?
It's a bit of a I was having a conversation recently. I was in New York, and we were talking about healthcare costs. And we were like, and someone said, like, why is healthcare so expensive? And I was like, and I'm not the first person to say this. I don't remember where I heard it, so I'm not going to take all the credit. But it was like, healthcare is expensive because healthcare is expensive, because we charge that much, because it costs that much, because it costs that much. Like, when you go into the hospital and then you have to pay them their facility fees, you know, just to be there. It's because they charge that much money for their facility fees. And we've created, and then if you look at the whole system too, I mean, it is complicated, but it's simple in some ways too. And again, it kind of goes to the concept of, you know, our cost is someone else's revenue. It costs so much because other people want to make as much revenue as they can. Is because the hospital down the street, even though it's a nonprofit, which is really just means tax exempt, they have bondholders, they need to build, they have a lot of people to pay, they want to make a bunch of money because we live in a big capital society. There are all these factors that you really have to keep going levels up to look at even our macroeconomic system to know that it's about making money. It's about maximizing revenue. It's about maximizing profit. So that's why it's, I mean, honestly, like the simplest answer is that it is expensive because it's expensive. And our society socially is governed largely by a capitalist market system. And the purpose of a capitalist market system is to create wealth and to make money. So that's kind of the simplest answer of it. A lot of dynamics, obviously, but
it's expensive because it's expensive.
Yeah.
Now, I want to offer a little nuance to that. And again, you tell me whether or not you disagree. I've heard it said that it's expensive because we allow it or we permit it to be expensive through a bunch of different mechanisms. I'm not saying that, you know, it's as simple as, okay, well, I'm just going to not let it be expensive. But, you know, there's a lot of opacity in healthcare, which prevents us from being able to know beforehand whether or not it's going to be, or exactly how expensive it's going to be. Mm-hmm. And so we don't have the opportunity beforehand in many cases to say, I don't like that. Let me go find somebody else. Right. What are your thoughts on that?
Yeah, I would agree with that to a degree, because and something you called out too as part of saying that it does become so complex quickly. And part of that complexity is human psychology. So, and I would maybe argue that how our government is set up as well, because there's a couple mechanisms, I suppose. Mechanism one is policy. So we have the ACA. There's some legislation that gets passed here and there about healthcare, and it just is piling on top of a already kind of amalgamated, you know, the hydra, as it were. And most people don't feel like there's anything they can do about that. You can't influence it. How do you change the government? How do you change policy? What does that even look like? Do I become a lobbyist, go on Capitol Hill? Do I vote next year, next 2 years, next 4 years? I mean, what can I do, you know, about it? So there's a big psychological factor there. And that's policy. And the other side is to say, well, I don't need that. I'm just going to go direct, or I'm going to go figure it out on my own, but then that's a whole different kind of ball of wax, because I do think that there is a psychological element that if we really looked at the entire population and thought of the people who have the time, the wherewithal, the resources, financial or otherwise, to say, I'm not going to deal with this anymore, this insurance game, this nonsense, this whatever. I'm just going to go find an incredible direct primary care doctor. I'm going to do only like direct pay. I'm going to get a medical cost share, and I'm going to do this research. I mean, that's a lot. That's a big effort to do that. I know when I go in that I'm going to say I don't have insurance, I need cash rates, and then I know how to handle that conversation with the person at the urgent care because I'm traveling. If we're have to go to the hospital, I know the right things to say, and I know how to get my financial assistance or argue with a bill. I mean, there's sort of a lot to it. So I think most people just say, it's fine, I'll figure it out. I don't know. I'm at the mercy. I'm just trying to make it. I'm just trying to, pay $200 a week these days for groceries or whatever it is. I've got to spend $5 on gas per gallon. I can't, I know it's money, but I just can't do one more thing. And I think employers feel the same in a lot of cases. They sort of have this broker that's this trusted individual that they've known for however long, and insurance is hard and complicated, and the contracts, 50 pages long with 50-page addendums and all. How do I'm trying to run a business here. I got to go do that now too. It's just we've made it so challenging to navigate. And that's just even the commercial side. They're not even touching Medicare or Medicare Advantage, which is a nightmare, ridiculous thing, or Medicaid, you know what I mean? And those are whole different mechanics of how do we want to behave as a society? What do we really want out of things? How do we take care of people? How do we show up for others who we feel like are part of either our state or our city or our country or whatever? I think it becomes so while I agree that it's sort of as expensive as we allow it to be, I think that most people just feel like how do they not allow it? Because they're just like, there's so little they could probably do. And so that's sort of maybe my only response to that is I agree with you. However, it is a really big challenge because there's so much to it.
Sure. I don't disagree with that. There's a lot of complexity there. But I would offer you this, that there doesn't have to be as much complexity. And we see in certain scenarios and in growing segments where that complexity is being pared down. And in some cases largely eliminated, much to the benefit of the patient, not just in terms of the patient's cost, but also in terms of the patient's outcomes. You mentioned direct primary care earlier, and that's the simplest example to understand. You have this gym membership, and it's instead of paying for every single fry that you get. When you go to the restaurant, you're like, yeah, I'll pay for that one fry. Oh, you're going to give me another fry? Oh, I'll pay for that one too. Oh, I have a whole plate of fries. I got to count out all of them and pay for them individually. Instead, you have a membership where you're like, okay, it's an all-you-can-eat buffet, and I can come in as many times as I need to. I'm going to pay a monthly fee. Eventually, what you do is you kind of moderate. I mean, you're not going to sit there and say, I'm going to stuff myself every single time I go. I'm going to go, 24, 23 hours a day, which is the fear, right? That's the fear that a lot of physicians have when they consider the possibility of a subscription model. They're like, oh my goodness. Yeah. They're going to treat me like an all-you-can-eat buffet.
But I agree, but that's what I mentioned earlier is that you have that fear. Right? I talk to so many doctors, and you might be one of them too, who are like, "Oh yeah, I give out my cell phone number," and these doctors are like, "What?" And I'm like, "I don't want to call you. Like, I like you. You're a nice guy. Like my doctor, but like, we're not buds. I don't want to text you, and I don't want to be sick, and I'm also not sick that often. So." There's this sort of fear that, oh my God, if I become accessible, then I'm just going to get hit. And most doctors say, I've given out my number for the last 12 years and 4 people have called me ever, So it's just this weird perception. Like, I don't want to go hang out at the doctor's office. So I'm still going to use it as little as humanly possible. But it gives you, it's funnily enough, a much more direct sort of almost insurance product, right? I pay $100 a month in case I need you during that month, as many times as I might need you during that month. And usually it balances and evens out. But yeah, it is interesting to think about it like that. And I'll also say that while it is highly complex and there's a lot to it, and to your point that it doesn't have to be, I do agree with that. And I think that individuals obviously always play a part in this, but the employer market, it stands to make the biggest impact and the biggest change. So employer healthcare spending to date is now around $1.2 trillion. And so, yes, highly fragmented, all the employers who are paying for health plans, that's a lot of money. And they're just going and saying, hey, United, my employees need healthcare. So can we just, you just tell them where they can go, and wherever you have contracts, they can go. And United's like, great. And then, but what are you really paying for? Again, you're paying for access to go pay for something based on their contracts. So their network is just a lot of contracts that they've already gotten. So you have one place to plug in, and then you avail of all their network contracts. Well, if we just said to ourselves, hang on a second, a network is just a bunch of people who have ultimately agreed on the cost of a thing that you're then going to go buy. And yeah, they pay sort of for some of it and whatever. But what if we just took them out of the equation and just said, hey, everybody out there, doctors, hospitals, everyone, tell us how much you need for this. Cool. You need that? Go pay for that. Or I'll pay for it. That's great. Like, yeah, I'm the employer. Let me pay for it. And then we've cut out this whole system of bills and prior auths and adjudications and back and forth and timing and cash flow issues. And they say, oh yeah, to come see you, it costs, $93. Great. All my employees, like, they're going to come see you, and I'm going to pay you $93 every time they come see you. Like, why do I need someone else to tell me that's okay to go do that? And then make sure it's done the right way and the right codes. And if you just say, no, I saw them, it's going to be $154. And I'm going to say, okay, that's what we agreed on. I trust you. That's what it's going to cost. So yeah, I mean, I think there's a lot to be said for it could be simpler, because if we just broke down again to sort of what is insurance, and what it is today is a whole bunch of contracts from between a third party that we pay for access to the contracts. Well, why do I need you? Why can't I just either go make my own contracts or create an infrastructure that allows a two-sided marketplace to come together to say, like, here's what it costs, and I want to go pay that because your value and that, this and that. And then let's get true insurance, which is stop loss on the backside for if, God forbid, someone gets cancer or an autoimmune disease and they need specialty drugs and whatever. And then I have a stop loss carrier that's real insurance that helps me with those costs.
Yeah. I mean, I can't disagree on any of those points. I agree with you 100%. So here's my question for you, right? So you talked a little bit on the front end here in our conversation about what you do for a living. Obviously, well, maybe not obviously. For those of you that don't know, Preston and I connected because we share some common thoughts and ideas when it comes to the affordability and the delivery of healthcare. So tell us what you are doing to help with whatever piece of this puzzle that you're trying to make better.
Sure. So, I mean, a couple things. So, in my intro, I mentioned kind of two areas, and really I boil them down to finance and law. I think that's a pretty big part of healthcare anyways, outside of the important part, which is clinicians taking care of people with their skill and know-how and just allowing for that relationship to exist. So, but where finance and law are concerned, again, on the law side, there's so many folks out there, clinicians, non-clinicians, people who have had a family member, people who've been impacted, whomever it is, who kind of look around and they say, this is ridiculous. I want to either create a solution, or I know a different way, or I've been with the hospital for 15 years and like I see what they're doing and I don't want to be a part of it anymore. Or I've been taking insurance and I'm over it. There's got to be a new model. Let me go out on my own. Let me be independent, or let me go join a group that I'm aligned with, and feel like I could be a good part of it. And that's what we, effectively do on the law side, is we support those starting out to go as, founders or entrepreneurs or growing businesses. They're like, we want to change something. We want to improve healthcare, improve access, improve outcomes. We have this way, whether that's, I want to be a, dirty words I know, but a traditional fee-for-service practice, and because it still has a place, and it's still, I got to serve the Medicaid population. I want to serve the Medicare population. There are people who are insurance and want care and want to use it. And, I'm part of that system, and that's fine. And we want to support that in the digital health companies and the health tech companies, because we need more of the right type of solutions with those people who believe that they can really impact and change and aren't just out there sort of money grabbing, I don't know, whatever sort of, which there are a lot of areas in healthcare. And then on the other side, the finance side, and we mostly on the finance side work some with startups, but mostly with private practices and physicians to just get better visibility into their numbers at the end of the day. So it's just really hard. Direct care models are different, and not that it's not a hard business, but there's something pretty it's almost like a unicorn in healthcare, right? When someone comes in and they pay you money and then they leave, and you know how much money you made on the, that's your revenue, your unit, every time you see a person. But most practices, especially in traditional healthcare models, it's like a black hole, right? They come in, what's your insurance? I don't know. We'll look it up. Okay. We bill a thing where we think we know what we should get paid, but who knows? And the patient owes this much, and I got to go chase. I mean, it's such a challenging environment, and sort of, notwithstanding a better alternative, we want to support those practices because, one, we see tons of physicians who operate in those models who do well and do incredibly well for their patients, and the outcomes are phenomenal and people are happy, and they've really designed around the failings of the insurance traditional model, where patients feel heard, they have more time, there's a much higher, better level. And we want to be able to support those types of businesses for what they're doing. So that's how we carve it out, and we help support some new startups in the consulting and launching practices too. So yeah, we're just trying to be out here and support, again, the pendulum swinging back to the right areas, and most of our clients across the board are just trying to get better connections with their patients, trying to have a better model, and they do amazing work, and we're lucky to be able to support them.
That's awesome. Okay, so as we tie up here today, I got 3 things that I want to run by you. Number 1, I don't know if you're aware of this, but this year the Free Market Medical Association is not having a national conference, but the Nebraska chapter is having our annual conference on the 21st of August. And I would like to extend a warm, friendly invitation if you feel so inclined to come and join in the conversation. As an attendee, we would love to send you the details so that you can make a decision for yourself. Do I want to fly out to Nebraska to meet these people and see what's what? No hard feelings if you say, oh, that's not a good fit for me, but we would at least like to extend you that invitation. We're trying to get as many people from all around the country to come, since there isn't a national conference. And I keep hearing on LinkedIn primarily that there's this hunger for this networking event that we have relied on for the last 12 years. But for some logistical reasons, we've had to postpone to 2027. So I extend that invitation to you. I'd be happy to send you the details so you can decide whether or not it fits into your calendar, or whether or not it's a good use of your time. So I offer that. Number 2, considering that our target audience is primarily medical students, physicians in training, and people who are recently out of training, for somebody that's considering going into an independent practice in the form of direct care, whether it's direct primary care, direct specialty care, maybe they're just curious about it. Maybe they don't know a whole lot. Maybe they know a whole bunch, and they're like, okay, I'm interested. I just don't know how, or somewhere in between. What would be the biggest piece of advice you would have for that person who's thinking about taking the leap and going into an independent practice model that's direct care?
Sure. I think my biggest piece of advice would be, it's a little bit twofold. I mean, one side is there's no great time to start a new thing, a practice, go out on your own, be an entrepreneur, what have you. But there's also no better time than now, as soon as possible, especially when you're early in your career, or just getting out of school. It feels safe, and you want to, a lot of debt that's involved, and you want, like, the hospital saying, yeah, but if you're already here, right, you're in training, so just here's the dotted line, and like, look at all the money, right? It's, you need that money. And so something very alluring about that, and people have financial realities, but I think the biggest thing is that there's a different type of upside when you can go out and practice on your own and do a model that just, you can build the healthcare delivery that you always probably envisioned before you have to say, oh my gosh, insurance is making my life a nightmare. So that's sort of my biggest piece, is just I tell people all the time that, I bully people into entrepreneurship because I think it's great and it's important, and they can, get a lot out of it. So that would be the biggest part. And then, secondarily, I would say, know your numbers, look at the unit cost of things, make sure you can cover your overhead. But at the same time, it doesn't have to be as big of a daunting endeavor. You don't need $1 million. You don't need a nice building. You don't need all this stuff. I mean, you can literally go sublease some space from, your doctor and say, yeah, every visit's going to be $99, or it's going to be a monthly for whatever. And then you can go tell people, and then they'll pay you money, and then you can see them,
Awesome.
Yeah.
Awesome. So last question. How do people find you?
I'd say LinkedIn. Find me on the LinkedIn. It's the easiest place to find me. And I spend much of my time there. I open DMs all the time. So just send me a note, and happy to see if I can help.
Perfect. Well, thank you, Preston, for joining us. It was exciting having another conversation with you. It's always edifying, and I really enjoy it. And I just want to say thanks. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.